So the murmurs that you have in pulmonary arterial hypertension, they are the functional murmurs, right? And you have two important murmurs. One is your early diastolic murmur, that is due to leakage of the blood from pulmonary artery into the right ventricle because of increase in your pulmonary arterial pressure. And the name of that early diastolic murmur, it is the Graham-Steele's murmur. And the other murmur that you can have is because of increase in the pressure within the right ventricle, there can be leakage of the blood from right ventricle to the right atria. And that is the murmur of tricuspid regurgitation, which will be pansystolic murmur. But remember, both of them, they are the functional murmurs. They are not the true murmurs. And there will be also parasternal heave. So why is that there is development of the parasternal heave is because of the right ventricular hypertrophy. So because of right ventricular hypertrophy, you can see the parasternal heave in the left parasternal area, right? You need to place the base of the hand over the left parasternal area and you can see that uplift. That is what is called as the parasternal heave. So these are the examination findings in patients with the pulmonary hypertension. And additional examination findings will be there in patients with pulmonary hypertension. That is depending upon the underlying etiology. Like patients with pulmonary hypertension, if they have clubbing, then what is that we need to consider is, we need to consider that it is the chronic lung diseases that is responsible for the development of the pulmonary arterial hypertension. Lung diseases like interstitial lung diseases, fibrosis of the lung parenchyma, these will cause the clubbing as well, and they can contribute to even development of pulmonary arterial hypertension. Actually, how does these lung diseases will cause pulmonary arterial hypertension? What is the mechanism is, in these patients with chronic lung diseases, there is development of the hypoxia. And what is the effect of hypoxia on the pulmonary artery? That will cause pulmonary artery vasoconstriction. And because of this pulmonary artery vasoconstriction, that will cause increase in the pulmonary arterial pressure, causing pulmonary hypertension. And scleroderma. See, scleroderma, which is a connective tissue disorder, that is also responsible for the development of pulmonary hypertension. Now, in scleroderma, what will be the examination finding is, you will notice that there is sclerodactyly, right? There is sclerodactyly, and there is also the telangiectasias. So, okay, so these telangiectasias, they are nothing but the dilated capillaries, right? So that is about your scleroderma examination findings. Then next is the CREST syndrome. CREST syndrome, it is a part of the localized scleroderma. So what will be the findings in case of your CREST syndrome? C stands for calcinosis. Then R is the presence of Raynaud's phenomenon, right? And E stands for esophageal dysmotility. S stands for sclerodactyly. Then T stands for telangiectasia. So your CREST syndrome is nothing but your localized scleroderma. Now, bilateral basal crepitations. In which etiologies of pulmonary hypertension you can have bilateral basal crepitations is, if suppose, if the pathology is the left side of the heart, then the individual can have increase in your pulmonary capillary wedge pressure causing pulmonary edema, and that is what is responsible for your bilateral basal crepitations. So what are those left-sided heart pathologies causing pulmonary hypertension? Just now we have discussed mitral stenosis, any condition causing left ventricular dysfunction, either it is aortic stenosis or aortic regurgitation or mitral regurgitation or coronary artery disease or your cardiomyopathies. Any condition which is causing left ventricular dysfunction can also cause your pulmonary arterial hypertension. And we have a WHO classification of your pulmonary hypertension, which I'll be discussing subsequently. That is, so if you take the classification of pulmonary hypertension according to World Health Organization, so we divide the entire etiologies of pulmonary hypertension into 5 classes, that is group 1, 2, 3, 4 and 5. So group 1, see how is this classification being made? Remember, that is based on the right heart catheterization. By right heart catheterization studies, right, you know, we classified the etiologies of pulmonary hypertension into 5 groups. And we have another etiology, that is pre-capillary and post-capillary. I'll discuss that in detail. But what is this group 1? See, group 1 is that it is idiopathic. We don't know what exactly is the cause. It could be genetic, it could be some drugs, and it could be due to accumulation of abnormal metabolites. So group 1, it is considered as idiopathic pulmonary arterial hypertension. We don't know what exactly is the cause for the development of pulmonary hypertension. Whereas group 2, this will be your left heart pathologies. What will be that left heart pathologies? Just now we have discussed mitral stenosis or any condition whichever is causing left ventricular dysfunction. And group 3 will be the chronic lung diseases. Okay, so it is primarily lung diseases or sleep disordered breathing, right? And what will be that sleep disordered breathing? That is obstructive sleep apnea. That will be your group 3 for the development of pulmonary arterial hypertension. And group 4 is the pathology within the pulmonary artery itself. That is chronic thromboembolic pulmonary hypertension. Then group 5, right? So this will be the rare or miscellaneous causes for the development of pulmonary hypertension. Okay, right? Some rare causes. Which are those? I'll give you a clear picture. What are those rare causes or miscellaneous causes causing pulmonary hypertension? So these are the 5 groups which have been classified by World Health Organization based on the right heart catheterization. And based on your right heart catheterization, the other classification which has been made is, that is isolated precapillary and isolated postcapillary hypertension. First of all, where exactly is the division? Let me just show you an image. So if you see the image, now this is the pulmonary artery, right? And from this pulmonary artery, it is dividing into the right pulmonary artery and as well as the left pulmonary artery. And this pulmonary artery is continuing, and at this point you have the pulmonary capillaries, right? At this point you have the pulmonary capillaries. Okay, now this pulmonary capillary, it is being continued as the pulmonary vein, right? It is being continued as the pulmonary vein. Okay, and these pulmonary veins, they enter into, right? These pulmonary veins, they enter into the left atria. Same thing even is on the other side of the lung as well. So now the part of the vessel before the capillary, right? This is the part of the vessel before the capillary. So this we call it as the precapillary, right? And the part of the vessel after the capillary, see, this is the capillary, right? After the capillary, what you have is a pulmonary vein, and that will be your postcapillary, right? So the another etiology of how this pulmonary hypertension is being classified is isolated precapillary and as well as the isolated postcapillary. Now, what are the causes for isolated precapillary causes for pulmonary hypertension? This includes primarily lung disease like interstitial lung disease, fibrosis of the lung parenchyma, all these. Then the other etiology is chronic thromboembolism causing pulmonary hypertension, right? Chronic thromboembolism causing pulmonary hypertension. So these are the causes for the isolated precapillary. Then what are the causes for isolated postcapillary? The isolated postcapillary, that will be mitral valve pathologies in the form of mitral stenosis and then left ventricular dysfunction, right? And then left ventricular dysfunction. And the development of this left ventricular dysfunction, it could be due to any reasons, right? Either MR or AR or AS or coronary artery disease or dilated cardiomyopathy, anything. So this is what is your isolated precapillary and isolated postcapillary. But occasionally, you know, there can be combined pre and as well as post capillary causing pulmonary arterial hypertension. Okay, so this is about like how do you grade or how do you group the pulmonary arterial hypertension according to your WHO classification. Now, after having discussed about the clinical features, now let me take up the discussion of the diagnosis, right? So once clinical suspicion is raised, a systemic approach to diagnose and assessment is very much essential. Now, how will you diagnose? You have multiple investigations. These investigations, they include ECG, then the 2D echo, then the gold standard investigation will be right heart catheterization, then chest x-ray, and particularly in patients with chronic thromboembolic pulmonary hypertension, right? what you need to do is CT, pulmonary angiography, right? CTPA stands for CT, pulmonary angiography. Then HRCT is another important investigation. Next, you need to know what will be the findings in sleep studies, what will be the findings in the pulmonary function test. Okay, so these are all the various investigations, but gold standard will be right heart catheterization, and first line investigation will be the two-dimensional echocardiography. So let us discuss one by one, right? What will be the changes that you will be observing in these diagnostic investigations? So the first thing is the ECG. So like in the ECG, you will have the abnormalities in the right-sided leads. What are those right-sided leads? The right-sided leads are V1, V2, V3, and you also notice the abnormalities in V5, V6 as well. But what is the abnormality in V5, V6? I'll tell you. First of all, what will be the abnormality in V1, V2, V3? So in V1, V2, V3, you will notice that there is presence of dominant R wave, right? You will notice the presence of dominant R wave in V1, V2 and as well as V3. And not only that, if you take the R by S ratio in V1, V2, V3, it will be more than 1. And these patients, right, if you take lead 1 and as well as lead 2, you will notice that there is presence of right axis deviation. And apart from these changes, that is dominant R wave in V1, V2, V3 and R by S ratio more than 1, you will notice that there is asymmetrical T wave inversion, right? Asymmetrical T wave inversion in V1, V2, V3. And this asymmetrical T wave inversion which is there in V1, V2, V3, that is what is suggestive of the strain pattern, right? That is what is suggestive of the strain pattern. That is what you will observe in V1, V2 and as well as V3. Then you take in case of V5 and as well as V6. So in V5, V6, you will have the features of right ventricular hypertrophy. That is, you will have the deep S wave, right? You will have the presence of deep S wave in V5 and as well as V6. So these will be the features of the right ventricular hypertrophy. So how much will be the depth in the S wave in V5? It will be more than or equal to 10 mm, right? Whereas in V6, the S wave, it will be more than or equal to 3 mm. Okay, so that will be the depth of the S wave in V5 and as well as V6. Now let me show you that particular ECG. So you just observe here, right? Number one, you are having the dominant R wave in V1, V2 and as well as V3. And even if you take the R by S ratio, it is more than 1. And you are also noticing that there is the asymmetric T wave inversion in V1, V2, V3. And there is also deep S wave in V5 and as well as V6. So these are the ECG changes that you will have in patients with the pulmonary hypertension. Then followed by the ECG, right? The next another investigation is the chest X-ray. So in the chest X-ray, what is that you will notice? You will notice that there is presence of the prominent pulmonary arteries in the anterior-posterior view. So the anterior-posterior view, it shows prominent pulmonary arteries. Okay, both right and as well as left pulmonary artery, both of them are being prominent. That is what is being seen in the anterior-posterior view. And you will also notice that, so if you see the apex of the left ventricle, you will notice that it is slightly upturned. Okay, the apex is slightly upturned. That is what you will see in patients with the right ventricular hypertrophy. And in the lateral view of the chest X-ray, in patients with right ventricular hypertrophy, you will notice that, see, this is a sternum, right? This is sternum. And normally you have a retrosternal space. And what will happen to that retrosternal space is this particular retrosternal space, it gets obliterated, right? And this retrosternal space, which is obliterated, it is occupied by hypertrophied right ventricle. It is occupied by hypertrophied right ventricle. That is what you will observe within the chest X-ray. Then coming to the 2D echo. So in the 2D echo, you have to observe this pulmonary arteries and as well as the chambers of the heart in the apical 4-chamber view. And you also have to observe the heart in the 2-chamber short axis view. In the apical 4-chamber view, what is that you will notice is that you will notice that there is dilatation of the right ventricle and there is also dilatation of the right atria. Both RA and RV dilatation is there. Okay, that is what you will observe in the apical 4-chamber view. Then next is the 2-chamber short axis view. In the 2-chambered short axis view, what is that you will notice is that there will be flattening of the interventricular septum during the diastole, right? Flattening of the interventricular septum during the diastole, or there can be slight shift of the interventricular septum into the left ventricle, right? Why? Because of increase in the pressure within the right ventricle. So remember, in the apical 4-chamber view, you will notice that RA and RV is dilated, and at the same time, the 2-chambered short axis view, it will show that there is flattening of the interventricular septum. Okay, next. So this is about your 2D echo. Then followed by that, what will be the abnormality that you will notice in 6 minutes walk test? So what is the purpose of doing the 6 minutes walk test is, that is mainly to assess, right? That is mainly to assess the functional capacity. We do 6 minutes walk test. Okay, and 6-minute walk test will not only tell you about the functional capacity, it will also help in assessing the prognosis of the patients with the pulmonary arterial hypertension. And in case of severe forms of pulmonary hypertension, what will happen to 6 minutes walk distance? 6 minutes walk distance will definitely be reduced. Why? Because during the time of walking up to 6 minutes, the individual may develop dyspnea by 4th or 5th minute. So your 6-minute walk distance will be reduced in severe form of pulmonary hypertension, and that is because of dyspnea and as well as fatigue. Then the another important investigation is cardiopulmonary exercise testing. See, the purpose of doing this cardiopulmonary exercise testing is, this will differentiate, is it like cardiac cause for pulmonary hypertension, or is it like pulmonary cause for pulmonary hypertension. Cardiac causes will be like mitral stenosis and left ventricular dysfunction. Pulmonary causes will be like interstitial lung disease, fibrosis of the lung, chronic obstructive pulmonary disease, bronchial asthma, cystic fibrosis, all these. So this cardiopulmonary exercise testing will help us to differentiate whether it is a cardiac or pulmonary cause for dyspnea, right? And this particular cardiopulmonary exercise testing, right, this also measures peak volume of oxygen consumption, right? It also measures peak volume of the oxygen consumption. And this cardiopulmonary exercise testing, it also helps us in assessing the prognosis of the individual, okay, with pulmonary hypertension. That is the importance of your cardiopulmonary exercise testing, which help us to differentiate whether it is a cardiac or non-respiratory cause for the development of dyspnea. Right? And for suppose, right, if the cardiopulmonary exercise testing is being normal, right, that means the patient is having dyspnea, but we are not able to differentiate whether it is cardiac or pulmonary based on cardiopulmonary exercise testing, then these patients, they require invasive approach. Okay, so invasive approach, again, it is not every time required. This invasive approach, it is being rarely required, not always. Okay, because we have many other investigations to make out whether it is pulmonary or the cardiac cause for the development of pulmonary hypertension. Now, if at all, if you are doing the invasive, then what is the gold standard investigation for pulmonary hypertension? The gold standard investigation will be right heart catheterization. That will be the gold standard. Okay, for this right heart catheterization, it will not only help us in diagnosis of pulmonary hypertension, it also tells us about the assessment of severity of the pulmonary hypertension as well, right? Now, this right heart catheterization, it remains the gold standard test to establish the diagnosis of pulmonary hypertension, and it also helps us in guiding the treatment, right? What sort of treatment? Is it like monotherapy, or it is a combination therapy, or surgical therapy is need to be planned? That can be assessed by the right heart catheterization. So, and remember, it is an invasive procedure. It's an invasive procedure. Okay. Now, what is the diagnostic criteria for pulmonary arterial hypertension according to right heart catheterization is the mean pulmonary arterial pressure should be more than 20 millimeters of mercury. And this right heart catheterization also helps us in guiding the treatment. That is what we have discussed just now. And the other points, right? The other points are this right heart catheterization will also tell us whether it is the pre-capillary cause for pulmonary hypertension or is it like post-capillary cause for pulmonary arterial hypertension. In what way? Like for example, if it is like pre-capillary cause for pulmonary arterial hypertension, the pulmonary capillary wedge pressure will be less than 15 millimeters of mercury, right? If it is like post-capillary cause for pulmonary arterial hypertension, your right heart catheterization will show that the pulmonary capillary wedge pressure is more than 15 millimeters of mercury, right? Post-capillary means will be your left heart pathologies where your pulmonary capillary wedge pressure will be elevated. And not only that, if it is like isolated, so if it is isolated pre-capillary pulmonary hypertension, in isolated pre-capillary pulmonary hypertension, right heart catheterization shows that pulmonary vascular resistance is more than or equal to 3 Wood units. Okay, in isolated pre-capillary pulmonary arterial hypertension, right, the right heart catheterization shows pulmonary vascular resistance is more than or equal to 3 Wood units, whereas in isolated, right, post-capillary, the right heart catheterization shows the pulmonary vascular resistance as less than 3 Wood units, right, less than 3 Wood units. So that is the importance of your right heart catheterization. And there can be even combined. So this is isolated pre-capillary and isolated post-capillary. But if it is combined pre and post-capillary, then what does the right heart catheterization shows? If it is combined pre and post-capillary, the mean pulmonary artery pressure will be more than 20 millimeters of mercury, right? And pulmonary vascular resistance will be more than or equal to 3 Wood units, and pulmonary capillary wedge pressure will be more than 15 millimeters of mercury, right? More than 15 millimeters of mercury. So this is combined pre-capillary and as well as post-capillary hypertension, right? Now to summarize everything, whatever we have discussed. So the gold standard is what? Right heart catheterization. So in the right heart catheterization, you need to check the mean pulmonary arterial pressure. So if the mean pulmonary arterial pressure is more than 20 millimeters of mercury, then it is considered to be that the patient is having pulmonary hypertension. Okay. And if the mean pulmonary arterial pressure is less than 20, then you need to exclude the pulmonary hypertension. Now, once you find that the mean pulmonary arterial pressure is more than 20, then you are considering it as pulmonary hypertension. Immediately what you need to do is you need to check the pulmonary capillary wedge pressure or pulmonary arterial wedge pressure. If the pulmonary arterial wedge pressure is more than 15 millimeters of mercury, then, right, if it is yes, and at the same time you need to calculate the pulmonary vascular resistance. If it is more than or equal to 3 Wood units, then it is combined pre and post capillary pulmonary hypertension. If the pulmonary vascular resistance, it is not more than or equal to 3 Wood units, then it is isolated post capillary pulmonary hypertension. So what are the isolated post capillary pulmonary hypertension? Like your left heart pathologies like mitral stenosis and as well as left ventricular dysfunction. And if pulmonary arterial wedge pressure is, if it is not more than 15 millimeters of mercury, but pulmonary vascular resistance is more than or equal to 3 Wood units, then you need to consider it as the isolated pre-capillary pulmonary hypertension. That includes the idiopathic. Then group 3 will be your lung pathologies. Group 4 will be your chronic thromboembolic pulmonary hypertension. And group 5 will be rare causes or miscellaneous causes. And if suppose, right, pulmonary artery wedge pressure is not more than 15 millimeters of mercury, and at the same time pulmonary vascular resistance is also not more than or equal to 3 Wood units, then you need to exclude the pulmonary hypertension. Okay, so this is how you need to work up for the etiologies causing pulmonary hypertension based on the right heart catheterization. And the very important point you need to know is the grading. The grading of the pulmonary hypertension can be done by your right heart catheterization. So when do you call it as mild pulmonary arterial hypertension? We use the word mild pulmonary arterial hypertension when the pulmonary arterial pressure is more than or equal to 21 to 30 millimeters of mercury. And when do you call it as moderate? We use the word moderate if the pulmonary arterial pressure is like 31 to 40 millimeters of mercury. Then when do you call it as the severe? Severe pulmonary arterial hypertension is said to be the severe when the pulmonary artery pressure is more than 40 millimeters of mercury. That is what is called as the severe pulmonary arterial hypertension. So this is about how do you work up for the pulmonary hypertension etiology based on the right heart catheterization, right? Now, then followed by that, the other important investigations are the pulmonary function test. See, by doing your pulmonary function test, what is that you will be able to make out? Is it like obstructive lung disease causing pulmonary hypertension, or is it like restrictive lung disease causing pulmonary hypertension? But one of the very, very important thing that you need to know in pulmonary hypertension, pulmonary function test is that the DLCO, that is diffusion capacity of the lung for carbon monoxide. So diffusion capacity of the lung for carbon monoxide in patients with the pulmonary hypertension, remember, it is reduced. Okay, so isolated reduction in diffusion capacity of the lung for carbon monoxide is the classical finding in patients with the pulmonary hypertension. And the next investigation is the high resolution CT scan. So what is that you will notice is that there is enlargement of certain structures. What are those structures which are enlarged? Number one, the pulmonary artery is enlarged. Number two, your right ventricle is enlarged. Number three, right atrium is being enlarged. And what will happen to the peripheral vessels? Remember, the central pulmonary artery is dilated, but the peripheral small vessels, there will be peripheral pruning of the small vessels. That means they become attenuated, they become narrowed, they become very small. So peripheral vessels, there is like peripheral pruning of the small vessels, but the central vessel, there is enlargement of the main pulmonary artery. And in the HRCT, you will also notice the presence of the venous congestion. But this venous congestion is very prominent when there is left heart pathology, that is in the form of mitral stenosis or the left ventricular dysfunction. And you will also notice that the septa, right? The septa, it is being thickened, and you will notice within the lung that there is centrilobular ground glass infiltrate. Right? Centrilobular ground glass infiltrate. Okay, so that is what you will see in the HRCT, that is high resolution CT scan, right? And this peripheral pruning of the blood vessels, this is very, very important. The central pulmonary artery is dilated. In contrast, the peripheral blood vessels, they are like pruned, they are being lost. Okay, and the other importance of your HRCT is to distinguish the interstitial lung disease, emphysema, and as well as the overlap syndromes. What are these overlap syndromes? The overlap syndromes are the presence of the fibrosis and as well as the obstructive lung disease. That is what is your overlap syndrome. That is basically HRCT will tell you what is the underlying lung disorder as well. Then what will be the abnormalities of the sleep studies in patients with the pulmonary hypertension? See, what you have to do is, these patients in whom you are suspecting pulmonary hypertension, right, you need to do nocturnal oximetry screening. So basically those individuals who are having the sleep disturbances, in them you need to do sleep studies, and in that you need to check the nocturnal, or you need to do nocturnal oximetry screening. Okay, so either it might be obstructive sleep apnea, or it might be because of your obesity hypoventilation syndrome. Whatever it might be, if there is sleep disturbance causing dyspnea, you need to do nocturnal oximetry screening. And if it is pulmonary hypertension, what is that finding you will see in the pulmonary hypertension in the nocturnal oximetry screening? You will notice that there is nocturnal desaturation, which is a very common finding, right? Which is a very common finding in pulmonary hypertension. Okay, so that is about like what will be the sleep studies, right? Then after the sleep studies, now to diagnose chronic thromboembolic pulmonary hypertension, right? The investigations what we have is the CT angiography. Then what is that we will be doing in these individuals? Let me tell you. So this chronic thromboembolic pulmonary hypertension, this is very common in patients with past history of pulmonary embolism. Okay, in patients with past history of pulmonary embolism, that is past history of luminal pulmonary embolism, there will be development of chronic thromboembolic pulmonary hypertension. Now, in these individuals, what is that you will notice? You will notice that there is vascular fibrosis and there will be presence of the arterial microthrombi, right? Vascular fibrosis and arterial microthrombus within the vessel. That is what you will be able to make out with the help of CT pulmonary angiography. And these patients, most of the time, they are refractory to medical management. They have to undergo the surgical treatment, and that surgical treatment includes surgical right? That includes surgical endarterectomy, right? So that is about the treatment for chronic thromboembolic pulmonary hypertension. So like the two investigations, the definitive investigation is CT pulmonary angiography. The other investigation is the VQ scan. So why will you do this ventilation perfusion scan? That is only for screening of chronic thromboembolic pulmonary hypertension. Now this VQ scanning, that is ventilation perfusion scanning, that is primarily used to screen and diagnose, right? Screen and diagnose chronic thromboembolic pulmonary hypertension, right? And this should be considered in any patient with pulmonary hypertension of unclear etiology, right? Where you are not able to make out the etiology, in them you need to do VQ scan. So basically what will happen in this? So what this ventilation perfusion scan measures? The ventilation perfusion scanning is the test that measures the amount of air which is coming out from the lungs into pulmonary capillaries, and at the same time it will also test, that means it is testing your exchange of gases across the pulmonary capillaries, and at the same time it will also assess how is the blood flow to the lungs. So basically it will assess the blood flow to the lungs and it will also assess the exchange of gases. Okay. Now in patients with the pulmonary hypertension, what is that you will notice is that there is VQ scan mismatch, right? VQ scan mismatch. Why is that there is VQ scan mismatch? Okay. This particular VQ scan mismatch is due to decreased flow of blood into the lungs, right? Why? Because there is increase in your pulmonary arterial pressure. So because of that, right ventricular output into pulmonary artery will be reduced. So there will be decreased flow of blood to the lungs. And the next important thing is there will be impairment of exchange. Okay. Why? Because when the flow of blood to the lungs is not there, so there is no question of exchange. So you will notice that there is hypoxia and there is the hypercapnia. That is what you will be able to make out in the ventilation perfusion scanning, right? That is, so VP scan is a screening method for your CTE-PH. Then what is the definitive diagnostic test for your CTE-PH? That is CT pulmonary angiography, right? So that remains the definitive test and gold standard test. Then what is that it will show you? So it will tell you the morphology of the vessel, right? So this will tell you if there is any presence of webbing in the vessel wall. This will tell you if there is any stricture of the vessel wall, and this will also tell you if there is any vascular tapering within the vessel wall. Okay, webbing, stricture, and as well as the tapering pattern. If these are present, remember they are pathognomic for chronic thromboembolic pulmonary hypertension. And the another importance of your CT pulmonary angiography is that this will also tell you to plan the treatment, right? Is it like medical management or is it like surgical treatment, that is endarterectomy? So that also will be said by your CT pulmonary angiography. Now, what are the other investigations in patients with the pulmonary hypertension is the serology. See, there are certain viral infections which will be causing pulmonary hypertension like HIV, right? So you need to do the testing for the serology of the HIV, right? That is your PCR. Then the another important is the viral hepatitis, right? So you need to test for this serology of this hepatitis virus and as well as the HIV to rule out these viruses causing the development of pulmonary arterial hypertension. Then the testing of the antibodies. So at this, see, once you get this hepatitis virus being positive, at the same time you also need to do liver function test. The antibodies, we have some connective tissue disorders or autoimmune disorders causing pulmonary hypertension, like you need to test for the RA factor and as well as the anti-CCP, because your rheumatoid arthritis is one of the etiology that will cause pulmonary hypertension. Then you need to test for anti-SCL70 because that is mainly to rule out the scleroderma causing pulmonary arterial hypertension. So these are some of the antibodies that you need to test for to rule out the etiology. Then the another important is this methamphetamine. Methamphetamine usage is being increased in the recent days, and this methamphetamine levels in the blood also need to be tested to rule out methamphetamine causing pulmonary arterial hypertension. Next is the levels of NT-proBNP. See what is happening to the right ventricle. There is right ventricular stretch or there is right ventricular distension. So what will happen is there will be increase in the levels of NT-proBNP. Right? So NT-proBNP stands for, BNP is your brain natriuretic peptide. So NT stands for N-terminus propeptide. N-terminus propeptide brain natriuretic peptide. So that will be released from the right ventricle once there is right ventricular distension or right ventricular dysfunction. So what is the importance of your NT-proBNP is that your treatment should target to lower, right? Treatment should target to lower the levels of your NT-proBNP. So it is not only diagnostic, it also helps in therapeutic and as well as prognostication of this pulmonary vascular disorders. Then the another important investigation is the vasoreactivity testing. So vasoreactivity testing is mainly done in case of idiopathic pulmonary arterial hypertension, right? Mainly done for idiopathic pulmonary arterial hypertension. So this idiopathic or hereditary causes for pulmonary hypertension, in them you need to do vasoreactivity testing. But why is that you have to do for your idiopathic or hereditary causes for pulmonary arterial hypertension? And with the help of which substances you need to do this vasoreactivity testing? So you need to use the vasodilators which are having short duration of action. Right? Vasodilators with short duration of action, with the help of those you need to do the vasoreactivity testing. And these vasodilators that we use is number 1 nitric oxide and number 2 inhaled ipoprostenol. Right? Nitric oxide and inhaled ipoprostenol, these are preferred for testing. So once you give vasodilators, when will you call it as the positive response? If there is decrease in mean arterial pressure more than or equal to 10 millimeters of mercury, then it is considered to be positive pulmonary vasodilator response test, right? And these responders in whom you have positive response, they have to be given calcium channel blockers as a treatment. So they have to be given long-term treatment of calcium channel blockers. And in those individuals where there is negative vasoreactivity testing, in them we need to give the drugs which will reduce the pulmonary arterial pressure. So to summarize whatever the groups and classifications we have discussed until now, I'll just show you a table. So right, so if you see this particular table here, first and foremost you have suspected pulmonary hypertension, then you do first line investigation echo and then ECG. Now, so you have suspected pulmonary hypertension based on clinical features, then you do a first line investigation 2D echo. Then you need to differentiate whether the development of pulmonary hypertension, is it like left heart pathology, is it lung pathology, is it like chronic thromboembolic pulmonary hypertension or some rare or miscellaneous causes. So For that, you need to do right heart catheterization. It's a definitive procedure. So once you do right heart catheterization, you need to measure mean pulmonary arterial pressure that should be more than or equal to 20 millimeters of mercury. And at the same time, your pulmonary vascular resistance should be more than or equal to 3 Wood units, right? Now, if both of these are not there, then alternative non-pH causing of the symptoms should be looked for. And if the pulmonary artery wedge pressure is less than 15 and you don't have any other cause for pH, right? There is no lung pathology, there is no left heart pathology, there is no pulmonary embolism, then that comes under your group 1 of pulmonary arterial hypertension. Okay. Then if pulmonary arterial wedge pressure is more than 15 with mean pulmonary arterial pressure more than 20, then you need to suspect the left heart pathology, that is mitral stenosis or left ventricular dysfunction. And if mean pulmonary arterial pressure is more than 20 and pulmonary vascular resistance is more than 3 Wood units and pulmonary arterial wedge pressure is less than 15, then you need to look for lung pathologies. If they are there, then it is suggestive of lung pathology causing pulmonary hypertension, that will be your group 3. Then if mean pulmonary artery pressure is more than 20 and pulmonary vascular resistance is more than or equal to 3 Wood units and pulmonary arterial wedge pressure is less than or equal to 15 millimeters of mercury, then what you need to do is you need to do VP scan, you need to do CT angiography. Then if it is there, if it is positive, then it is suggestive of your chronic thromboembolic pulmonary hypertension. Then the next one is if mean pulmonary artery pressure is more than 20 and pulmonary vascular resistance is more than 3 Wood units and pulmonary artery wedge pressure is less than 15 millimeters of mercury with the presence of comorbid diseases, then you need to suspect rare PAH subtypes. So this is about the workup of making out the etiology of the pulmonary hypertension. Now, you see this particular table, this will show you all the etiologies causing pulmonary hypertension, that is idiopathic, right? So we have sporadic, familial, drugs and toxins, persistent pulmonary hypertension of the newborn, that is genetic disorder, then pulmonary capillary hemangiomatosis, and associated with other active conditions like collagen vascular disease, congenital systemic to pulmonary shunts, portal hypertension and HIV. This will be your class 1. Idiopathic, we don't know what exactly is the underlying cause. Then pulmonary venous hypertension, that will be your group 2. Then lung pathologies, that will be your group 3. Then chronic thromboembolic, that will be group 4. Miscellaneous like sarcoidosis, chronic anemia, histiocytosis, lymphangiomatosis and schistosomiasis, that will be your group 5. Particularly, you need to be very much aware of the drugs and toxins, right? Drugs and toxins causing pulmonary arterial hypertension. Now, what are these particular drugs? These drugs, they are mainly the one which are used as the appetite suppressant drugs. Actually, they are used in the treatment of obesity. These drugs are aminorex, then fenfluramine, and the other important drug is dexfenfluramine, next is we have an oil, that is rapeseed oil, that can contribute to the development of pulmonary hypertension, right? So, and next is amphetamines. Just now we have discussed, that is methamphetamine. Okay, so these are the drugs, you know, they can contribute to the development of group 1 pulmonary arterial hypertension. Okay, and even some drugs of abuse like cocaine and phenylpropanolamine. PP stands for phenylpropanolamine. Then L-tryptophan. Okay, so these are the drugs and toxins which are responsible for the development of pulmonary arterial hypertension. So this is how we need to diagnose the pulmonary hypertension. Now, once the vasoreactivity testing is negative, we cannot give your calcium channel blockers. Then you need to give pH lowering drugs. Now, let me discuss what are those pH lowering drugs. So now let me discuss the treatment of the pulmonary arterial hypertension. So you have the pharmacological treatment, that is one important, and the other one is surgical treatment. But surgical treatment is mainly for the chronic thromboembolic pulmonary hypertension. So with the advent of the pharmacological treatment, the mortality has grossly reduced in patients with the pulmonary arterial hypertension. Before the advent of this pharmacological treatment, the 1-year mortality rate was nearly around 68% and 3-year mortality rate was around 48% before the advent of the pharmacological drugs. Now, all these pharmacological drugs, what they are targeting is, they are targeting the prostacyclin, nitric oxide, and as well as the endothelin receptors. So, taking the target of these three molecules, that is these three substances, that is prostacyclin, nitric oxide, and endothelin receptors, there are totally 14 FDA approved drugs for the treatment of the pulmonary arterial hypertension. And what are the various routes of administration of these drugs? These particular drugs, they are given through oral route, then intravenous, and as well as the inhalational route as well. So these are the various routes by which these prostacyclin, nitric oxide, and endothelin receptor antagonists are being used. Now, after the advent of the pharmacological therapy, what has happened to the mortality rate? It has grossly reduced, and there is improvement in the survival rate, right? There is increase in the 1-year and as well as 3-year survival rate. So how much is the survival rate increased after the advent of the pharmacological therapy? Is 91% 1 year, 69% survival rate, which is improved after 3 years. Okay. Now, what are these drugs? Let us discuss in detail. So I said you, like, we have the prostacyclin analogs, or we call it as the prostanoids. Then we have the drugs which will increase the nitric oxide levels, which will cause pulmonary artery vasodilatation, causing reduction in the pH pressure. And endothelin receptor antagonists, even they also will cause the pulmonary artery vasodilatation, causing decrease in your pulmonary artery pressure. First, let me take up the discussion of the prostanoids. So now, if you take the pulmonary arterial hypertension, there is development of, or there will be endothelial dysfunction and as well as the platelet activation. These two will cause imbalance of arachidonic acid metabolites. And once there is imbalance of the arachidonic acid metabolites, there will be reduced prostacyclin levels. And not only reduced prostacyclin levels, this imbalance in the arachidonic acid will also contribute to increase in the thromboxane A2 levels. Okay, will reduce the prostacyclin levels and will also increase the thromboxane A2 levels. Now, among this particular prostacyclin, we have PGI2, that is prostaglandin I2. What it does? This prostaglandin I2, it activates the cyclic AMP. Right? It activates the cyclic AMP dependent pathways that will mediate vasodilatation. Okay, so it will activate, the PGI2 will activate cyclic AMP dependent vasodilatation. And this PGI2 will not only cause vasodilatation, it also has anti-proliferative effects on vascular smooth muscle. Okay, the other effect of PGI2 is it has anti-proliferative effect or effects on vascular smooth muscles, right? So because of this anti-proliferative effect, the thickness of the vessel wall will not increase and there will be no decrease in the size of the vascular lumen, right? And not only that, this PGI2 will also inhibit the platelet aggregation. Right, will also inhibit the platelet aggregation. So that is what the PGI2 does. Now, what do we want? Your endothelial dysfunction and platelet activation in case of pulmonary hypertension is causing imbalance of arachidonic acid metabolites, that is reducing the prostacyclin and that is increasing the thromboxane A2. What we want now is, we want increase in the prostaglandin I2 levels or prostaglandin levels. One among that is your PGI2, which has vasodilatory effect, which has the anti-proliferative effect, which has the platelet inhibitory effect. Right? Now, what are these prostanoids or what are these prostaglandin analogs? So what we have to give now, the group of drugs that we need to give is the drugs which will increase the prostaglandin levels. Okay, what they will do? They will cause vasodilatation. They inhibit the proliferation. They also inhibit the platelet aggregation. Okay, so these drugs, one of that is the epoprostenol. So if you take this epoprostenol, this is the one which is the first available prostanoid, and the route of administration of this epoprostenol is in the form of the intravenous infusion. And what is the efficacy when you give this epoprostenol, which is a prostanoid? It will improve the functional capacity, that means dyspnea and fatigue will be reduced, and it will also improve the survival of the patients. So basically it will reduce the mortality rate. So like which class, which functional class it is improved by your epoprostenol? So you can give this in WHO functional class 3 and as well as the functional class 4. So once you give this in WHO functional class 3 and functional class 4, the onset of dyspnea, fatigue can be reduced. And the another important thing in the efficacy is that it will also improve the quality of life, and it will also reduce the mean pulmonary artery pressure, and it will reduce the pulmonary vascular resistance, and it will also improve 6 minutes walk distance. That is what is the efficacy of the epoprostenol. And one more prostanoid next to your epoprostenol is that is your treprostinil. So what does your prostanoids do? That is basically your PGI2. It causes pulmonary artery vasodilatation. It will inhibit the proliferation of the smooth muscles, right? And it also causes decrease in the pulmonary artery pressure. Now if you take this treprostinil, it is having longer T-half compared to epoprostenol, right? And because of that, the frequency of supplementation of the treprostinil will be reduced compared to that of the epoprostenol. And the route of administration is the subcutaneous route of administration, right? Subcutaneous route of administration. Okay. So how much will be the T-half of your treprostinil? We are saying that it is long T-half. It is almost 4 hours. It's almost like 4 hours. Whereas you take this epoprostenol, it is having the half-life of only 6 minutes. That is the reason why we are giving it as the continuous IV infusion. Whereas your treprostinil is having a half-life of 4 hours. That is the reason why we are giving through the subcutaneous route. And if you take the efficacy wise, it will reduce the symptoms of the pulmonary hypertension. That is 1 point. And it will also improve the exercise capacity. Right, it will also improve the exercise capacity, and it also improves the survival in patients with the pulmonary arterial hypertension. So that is the efficacy of the treprostinil. And we have the inhaled form of the treprostinil and one more prostanoid, that is iloprost. Now what is the advantage of this iloprost and as well as the treprostinil? So the inhaled form, it has the beneficial effect on the infused forms. What are those beneficial effect? See, in the infused forms, there is chance of infection at the IV site, right? Number 2, there can be infusion site reactions. So that can be overcome by your inhaled prostanoids, that is iloprost and as well as the treprostinil. And what is this inhaled iloprost and treprostinil being used is, it is used in the treatment of pulmonary artery hypertension by decreasing the pulmonary artery pressure, and it will also reduce the severe heart failure symptoms. That is the advantage of your inhaled iloprost and as well as the treprostinil. And we also have the oral formulations, that is oral prostacyclin. But these oral prostacyclins, they are not being used as the first line. this oral prostacyclin is also efficacious in clinical trials, but the maximal dose is modest and therefore generally it is reserved as the second line treatment, right? Generally reserved as the second line treatment for the development of for pulmonary arterial hypertension. So this is about your prostanoids. So three prostanoids. One is epoprostenol, second one is iloprost, and third one is treprostinil. And epoprostenol IV infusion, treprostinil subcutaneous and as well as inhalational. Iloprost, it is only the inhalational form. Okay. Then we have a non-prostanoid diphenpyrazine. That diphenylpyrazine, that is nothing but selexipag. And this selexipag, it is also the one which will bind to prostaglandin I2 receptor. By binding to prostaglandin I2 receptor, and for prostaglandin I2 receptor, this selexipag, it is having very high affinity. Right? Selexipag is having very high affinity by binding to the prostaglandin I2. Now, the active metabolite of selexipag, it has a prolonged half-life. Okay, it is having it is having a prolonged half-life in comparison to the prostanoid analogs. See, prostanoid analogs, you have like epoprostenol, 6 minutes is the half-life. Then we have treprostinil, which is only 4 hours is the half-life. So, but whereas the selexipag, it is having a longer half-life compared to that of your prostanoid analogs. And that is the reason why the dosing is only twice daily, right? Only twice daily if you give selexipag, that will be more than enough. And the efficacy of this selexipag is that it is given in functional class 2 or functional class 3 of the WHO, wherein the symptoms reduce. But you have to give this selexipag in combination with endothelin receptor antagonist, or it has been given in combination with sildenafil. Okay, so that is about your selexipag, which is an oral formulation, which is a non-prostanoid diphenylpyrazine. And this selexipag, the another important advantage is that because it is reducing the dyspnea of function class 2 or 3, it has been found to reduce the risk of hospitalization, and it will also reduce the disease progression. Right? It will also reduce the disease progression by 43%. Right? It will also reduce the disease progression by 43%, but when compared to placebo. Okay. So that is about your selexipag, which is an oral non-prostanoid diphenylpyrazine. Then we have endothelin receptor antagonist. We have two subtypes, that is endothelin A and as well as endothelin B. Now first let me tell you the mechanism of action of this endothelin receptor antagonist and what are the effects of the endothelin 1. So mechanism of action of this endothelin receptor antagonist is that they will inhibit the detrimental effect of the endothelin 1. Right? What is this endothelin 1? What it does? It is a potent endogenous vasoconstrictor. So it will cause vasoconstriction and thereby it will increase the pulmonary artery pressure. And endothelin 1, it also has vascular smooth muscle mitogenic activity. Right? So by having this vascular smooth muscle mitogenic activity, what it does is it increases the proliferation of the vascular smooth muscles and thereby decreases the vascular lumen and increasing the pulmonary artery pressure. Now, if you take the effects of the endothelin 1 because of these, because of vasoconstriction and because of vascular smooth muscle mitogenic activity, this endothelin 1 will increase the pulmonary vascular resistance, will also increase the mean pulmonary arterial pressure, and it decreases the cardiac output and it also decreases the 6 minutes walk distance. Right? Also decreases the 6 minutes walk distance. So that is about the effect of endothelin 1 on the individual. Now, we want the endothelin to be antagonized. So we have two subtypes, that is endothelin A and as well as the endothelin B. So this endothelin A and as well as endothelin B, where is it being expressed? It is expressed in right? It is expressed in pulmonary artery smooth muscle cells. Right? It is expressed in pulmonary artery smooth muscle cells. By expressing in the pulmonary artery smooth muscle cells, what it can cause is, it will cause the vasoconstriction. Right? It will cause vasoconstriction. That is what is the effect of the endothelin A and as well as the endothelin B. So now we have 3 endothelin receptor antagonists. Right? Out of these 3, we have 2 which are non-selective. Right? What do you mean by the word non-selective antagonist? Non-selective antagonist means they will block endothelin A and as well as endothelin B receptor as well. And the example of your non-selective are, number 1, bosentan, and the other important drug is macitentan. These 2 are non-selective endothelin A and as well as B antagonist. Then we have another important, that is selective endothelin receptor antagonist, and that selective endothelin receptor antagonist that will block mainly endothelin A. Example will be ambrisentan. Right? Example will be ambrisentan. So these are the 3 endothelin receptor antagonists. Now let us try to discuss one by one. You take this bosentan first. So if you take this bosentan, it is a non-selective endothelin receptor antagonist. What it does is, it improves, right? It improves the hemodynamics of the pulmonary arterial pressure. And the next thing is, it also improves the exercise capacity within the individual. Right? Improves the hemodynamics, and it also improves the exercise capacity of the individual, and thereby it delays the clinical worsening. Right? Thereby it delays the clinical worsening. Okay? That is the importance of the bosentan. Right? So the clinical condition of the patient will be improved, in the sense there will be no dyspnea, there is decrease in the fatigability. Right? There will be no syncopal attack, there will be no development of your edema. Now, if you take this endothelin receptor antagonist, we have 3 drugs: bosentan, right, macitentan, then ambrisentan. We have almost 4 trials for the endothelin receptor antagonist. These trials include BREATHE trial, EARLY trial, ARIS trial, and SERAPHIN trial. So if you take all these trials now, right, so one is your BREATHE trial. So BREATHE trial, it stands for bosentan randomized trial of endothelin receptor antagonist therapy. So what it says is, bosentan is definitely more efficacious than compared to that of your placebo in the treatment of pulmonary arterial hypertension. Then the EARLY trial, that is endothelin antagonist trial in mildly symptomatic pulmonary arterial hypertension patients. And next is ARIS trial, that is mainly for ambrisentan in pulmonary arterial hypertension. Then SERAPHIN trial, that is endothelin receptor antagonist in pulmonary arterial hypertension, to improve the clinical outcome. So these are the 4 important trials for the endothelin receptor antagonist. So out of which the first one is the BREATHE trial, that is for bosentan. So what this BREATHE trial tells you? So this is definitely a randomized trial. What they have taken is, they have taken a population which has been split into 2. So for one group, bosentan has been given. For another group, just only placebo was given. So for that particular group in whom bosentan was given, in them there was improvement in the symptomatology. Right? So in the sense, right? So there was decrease in the development of dyspnea, decrease in the progression of the dyspnea, decreased fatigability, and decreased syncopal attack. Okay? And even there was improvement in 6 minutes walk distance, and even there was improvement in WHO functional capacity. Right? Improvement in WHO functional capacity in patients treated with bosentan. And the other one is the EARLY trial. See, EARLY trial also, here also, this EARLY trial compared bosentan with the placebo. And what it has shown that is, bosentan, it reduced the pulmonary vascular resistance, and it improved 6 minutes walk distance, right? And it also improved improved the functional class in the individual. So that is about your early trial. So early trial and as well as breath trial, both of them, right, what they have used is bosentan versus placebo, and they found that bosentan is definitely highly superior than compared to that of the placebo. Then next, coming to your ARIS trial. So ARIS trial, that was for mainly ambrisentan, right, that was mainly for ambrisentan, that was compared by giving placebo to the other group of individuals. So a population was taken, for one group ambrisentan, the other group only placebo. So what this ambrisentan has shown, that is ambrisentan, it improved exercise, right, exercise tolerance. That means the fatigability and dyspnea has been reduced. And next, it also improved the WHO functional class of dyspnea, and it also improved the quality of life, and it also improved the hemodynamics in patients with the pulmonary hypertension. That is about ARIS trial, that is for ambrisentan. Then coming to the Seraphim trial. Seraphim trial, they have randomized almost 742 PAH patients, right? So one group was taking placebo and other group was taking macitentan. Okay, and what this has shown, again the same thing. This particular macitentan, it has improved efficacy. That means it has improved the functional classification, it improved 6-minute walk distance, it improved hemodynamics in patients with pulmonary arterial hypertension. So that is about endothelin receptor antagonist. So one class what we have discussed was the prostanoids, that is your ipoprostenol, iloprost and treprostinil. The other one is the endothelin receptor antagonist, that includes your ambrisentan, bosentan and as well as macitentan. And we have non-prostanoid diphenylpyrazine, right, that is oral formulation, that is selexipag. And the next group of drugs are nitric oxide pathway effectors. So this nitric oxide pathway effectors, if you see, this nitric oxide, it is a gaseous lipophilic molecule. And where is it generated from? It is generated from the endothelial cells, right? These endothelial cells, when they are acted upon by, right, when they are acted upon by endothelial nitric oxide synthase, right, when they are acted upon by endothelial nitric oxide synthase. So when they are acted upon by endothelial nitric oxide synthase, the endothelial cells will produce gaseous lipophilic nitric oxide. This gaseous lipophilic nitric oxide which is being released, that will activate, right, that will activate soluble guanylyl cyclase to the cyclic GMP, right? Where does this occur? This will occur within the, so conversion of your soluble guanylyl cyclase to cyclic GMP, it occurs in the vascular smooth muscle cells and it occurs even within the platelets. Now, what is the advantage of this cyclic GMP? Cyclic GMP, it is a second messenger. What it does is, it will induce vasodilatation, right? It will induce vasodilatation. How it will cause vasodilatation? By causing relaxation of, right, by causing relaxation of arterial smooth muscle cells, right? By causing relaxation of arterial smooth muscle cells, it will cause vasodilatation. And the other effect of cyclic GMP is that it also inhibits the platelet activation, right? It also inhibits the platelet activation. So that means basically it will inhibit the platelet aggregation. That is what the cyclic GMP does. Now, in order to improve the levels of your cyclic GMP, what we give is, we give phosphodiesterase 5 inhibitors, right? Actually, we have what is called as phosphodiesterase type 5 enzyme. Where is it being distributed? It is being distributed, or it is present within the lung vasculature, and it is also present in the corpus cavernosum of the male genital organ, that is penis. Now, what does this phosphodiesterase 5 enzyme does? This phosphodiesterase 5 enzyme, it will cause the vasoconstriction. So what we want now, we want this phosphodiesterase 5 enzyme to be inactivated, right? Okay. So this phosphodiesterase enzyme inactivation is being done by phosphodiesterase 5 inhibitors. Thereby, what is the advantage? Once your phosphodiesterase enzyme is inactivated by inhibitors, what will happen is there will be increase in the cyclic GMP levels. So what you want now? You want the increase in the cyclic GMP. Why? That will cause vasodilatation. And this cyclic GMP, it is inactivated by your phosphodiesterase enzyme. This phosphodiesterase enzyme is present in lung vasculature and as well as corpus cavernosum of the penis. So you have to inhibit that phosphodiesterase enzyme by your phosphodiesterase enzyme inhibitors. What it does, it will increase the cyclic GMP levels. So once the cyclic GMP levels increases, that will cause the nitric oxide induced or nitric oxide dependent vasodilatation. So thereby, once you give this phosphodiesterase 5 inhibitors, there will be vasodilatation, right? And once there is vasodilatation, there will be decrease in pulmonary artery pressure. And once there is vasodilatation, there is increase in the flow of the blood into the penile vasculature, and that will cause the erection of the male genital organ. So that is the reason why it is also used in the treatment of erectile dysfunction as well. Now, what are the examples of your phosphodiesterase 5 inhibitors? That includes sildenafil, and the other drug is tadalafil. Right, the other drug is tadalafil. So both of these drugs, what has been found is they have been shown to improve the hemodynamics in patients with pulmonary hypertension, and it has been shown to improve 6 minutes walk distance. Okay, that is the advantage of your sildenafil and as well as the tadalafil. Okay, next. Now after this, we have one more formulation which will increase the cyclic GMP apart from this phosphodiesterase 5 inhibitors, that is the riociguat. Right, that is riociguat. So riociguat, it increases the bioactive cyclic GMP. How it increases? Number one, it stabilizes the molecular interaction between nitric oxide and as well as the guanylyl cyclase. Okay, so it will stabilize the molecular interaction between nitric oxide and as well as soluble guanylyl cyclase. And the other thing is, this riociguat, it has directly stimulating action on soluble guanylyl cyclase independent nitric oxide bioavailability. So basically, what this riociguat does is, it is also the one which will increase the levels of the nitric oxide. Thereby, it increases the levels of the cyclic GMP. The only point is, it is not having that phosphodiesterase enzyme inhibitory activity, right? Now, if you take the efficacy, it will improve the hemodynamics, it will improve the WHO functional class within the individual, and it will reduce the clinical worsening, right? That is the advantage of this riociguat, right? And this riociguat, where is it used? It is the drug which is approved for chronic thromboembolic pulmonary hypertension, right? So where do we give this riociguat? In whom surgical pulmonary endarterectomy is ineffective. So where surgery is like contraindicated, there actually for chronic thromboembolic pulmonary hypertension, what the refractory cases, we plan for pulmonary endarterectomy. So in those individuals where surgery is contraindicated or ineffective in cases of chronic thromboembolic pulmonary hypertension, we give riociguat in these individuals. So that is about your riociguat, right? So what all drugs we have discussed? That is your prostanoids, that is your epoprostenol, iloprost and treprostinil. Then we have non-prostanoid oral drug, that is Selexipag. Then we have your group of drugs which will increase the levels of cyclic GMP, that is your phosphodiesterase enzyme 5 inhibitors, that is sildenafil and as well as tadalafil. Then we have endothelin receptor antagonists, that is ambrisentan, bosentan and macitentan. Now, what has been found is, how will you approach the treatment? Is it like monotherapy good or is it like combination therapy good? So the approach to PAH patients or PAH treatment has evolved substantially from the prior era in which success was defined by delaying mortality in the end stage. So by giving these drugs, the mortality was being delayed. Okay. So the goal of the treatment is the functional class of the WHO has to be improved. 6 minutes walk distance should be increased. It should be more than 440 meters once you give the treatment, and cardiac index has to be improved. That should be more than 2.5 liters per minute per meter square. That is the goal of the PAH treatment. Now, to achieve this particular goal, you need to give the drugs. That is the pharmacotherapy. Either monotherapy or combination therapy should be given. And risk factor modification, right? So, what is that risk factor modification? That is low sodium diet, then diuretic use in patients with group 2, that is group 2 like left heart pathology causing pulmonary hypertension, we give diuretics there, and supplemental oxygen mainly for group 3, 4 and as well as 5, and even in group 1 supplemental oxygen is also very much required. So by these you can achieve the goal. What is your goal? That is improvement in the WHO functional classification. 6 minute walk distance has to be improved to more than 440 meters, and cardiac index should be improved to more than or equal to 2.5 liters per minute per meter square. So now the point is like the combination of the drugs. So remember, combination therapy is more effective than compared to that of monotherapy. So for that you have trials. So what is the trial is? Ambrisentan plus tadalafil in pulmonary arterial hypertension trial, and that we call it as ambition trial. So what this ambition trial has done is, it has one group of patients monotherapy, the other group of patients combination therapy of ambrisentan plus tadalafil. So what was the result? Okay, what was the result was, so combination of ambrisentan and tadalafil, then compared to that of ambrisentan monotherapy or tadalafil monotherapy, what has been found was, when you give combination therapy, there was almost 50% lower risk of the clinical worsening when compared to that of monotherapy. That is what is your ambition trial. So combination therapy is more efficacious than compared to that of the monotherapy. And we have one more trial, that is registry data suggests that patients on dual therapy with phosphodiesterase 5 inhibitors plus endothelin receptor antagonist combination, alternative to drugs studied in ambition trial, also have better outcomes compared to patients treated with monotherapy. Even this also says that combination therapy is good than compared to that of monotherapy. So for that you have a flow chart. So what you need to do? The vasoreactivity testing. So once the vasoreactivity testing is positive, you need to give calcium channel blockers. So if you see the flow chart, in case of the new patients with pulmonary arterial hypertension, you need to do vasoreactivity testing. If the vasoreactivity testing is positive, then you need to give calcium channel blocker in this patient. And if the vasoreactivity testing is negative, then you need to give pH lowering drugs. So for high risk patients, you need to give combination therapy including IV. What do you mean by the word high risk patients? Those patients who are having the development of the heart failure, right? And those patients who have the syncopal attacks, in them you need to give the combination therapy including IV. But whereas low risk patients, right, where there is no syncopal attack in them you need to give combination therapy, like which will include the oral therapy. Okay. Now, in spite of giving the combination therapy, if the symptoms are refractory, in them you need to give the triple therapy, right? And in spite of triple therapy, if the symptoms are not subsiding, then you need to plan for the lung transplantation. So this is about the treatment of the pulmonary arterial hypertension. So these are the list of drugs for the treatment of pulmonary arterial hypertension, in which you have the prostanoids, that is epoprostenol, iloprost and treprostinil, and non-prostanoid oral drug, that will be your selexipag, which is a selective IP receptor and agonist. Then we have bosentan, ambrisentan and as well as macitentan, that is endothelin receptor antagonist, which are oral formulations. Sildenafil and as well as the tadalafil, right, they are phosphodiesterase 5 enzyme inhibitors, which can be given oral or IV. Sildenafil can be given IV. Riociguat, which is an oral formulation, which is SGC stimulator. So these are the FDA approved drugs for the treatment of pulmonary arterial hypertension. So this completes the discussion of this very important topic, that is pulmonary arterial hypertension. Thank you very much.